Hey all, welcome back to the Real Life Pharmacology podcast. This is a very special episode. This is actually audio from my 30 plus hour review course on Naplex and BCPS. So you'll find this along with nearly 30 hours of other video content. Those links you can find at meded101.com/store. Look for the BCPS section or the Naplex section, whichever exam you're potentially preparing for, and you will find this lecture with slides and everything else with it, along with obviously everything else that you need to know for these exams. So again, go check that out, meded101.com/store. Hopefully you pick up a few practice pearls on vancomycin, and this helps you prepare you for practice as well as your exams in the future. Vancomycin is a commonly used antibiotic, targets lots of gram-positive infections, but mostly synonymous with the use of MRSA. I'm going to get into a lot of important things in this lecture, so hopefully you'll come out with a little bit better understanding of vancomycin, some of the monitoring, dosing, and all that good stuff. So, quick overview, we're going to look at pharmacokinetics, dosing, as well as appropriate lab and drug level monitoring, and toxicity and adverse effects. All right, so a little bit about vancomycin. Mechanistically, it's considered a glycopeptide antibiotic. It inhibits bacterial cell wall synthesis, so this is similar in respect to penicillin antibiotics and cephalosporin antibiotics. But it does it by binding to D-alanine. This D-alanine sequence is important to the bacterial cell wall formation, so it prevents cross-linking and peptidoglycan formation. It is bactericidal in nature. All right, it's primarily used parenterally, so IV mostly, for empiric or target treatment of serious gram-positive infections, and like I said, especially Methicillin-resistant Staph aureus or MRSA. So in addition to MRSA, you may see it used for other gram-positive infections, particularly as an alternative to patients who maybe have an allergy to penicillin, those type of agents. Now, the oral formulation, I'm not going to talk about a ton here, but I will say it is a potential option in the treatment of C. diff infection. So the big reason why we don't use oral for, let's say treating a skin and soft tissue infection is we don't get adequate absorption through the GI tract with this medication. So, versus in C. diff, it's a gut infection, right? So we can get that antibiotic to the site of action by putting it in the gut. But if we need systemic absorption, oral administration is not going to accommodate for that. Indications-wise can be used for streptococcus, pneumoniae, MRSA, endocarditis potentially, off-label uses, skin and soft tissue infections, potentially some CNS infections. I'll talk a little bit about that more coming up when I talk about kinetics a little bit and those type of things. Also possibly some device-associated infections like prosthetic infections and things like that as well. All right, let's talk a little bit about spectrum of activity, a little deeper dive here. So gram-positive is really the most important thing to remember. And if you remember from microbiology, some of your gram-positive organisms, it's a pretty good bet that Vanco is going to cover it. So Streptococcus species, Enterococcus species, Staphylococcus species, MSSA, that would be methicillin-sensitive Staph aureus, as well as MRSA, methicillin-resistant Staph aureus. Now, MSSA, obviously we're probably going to use some of our penicillin antibiotics that generally are a little bit better tolerated and obviously don't need to be given IV in most situations. We can, have the option to give those medications orally and treat that. All right, one thing I wanted to point out with vancomycin resistance is we do have VRE, or vancomycin-resistant enterococcus species, okay? So that's an important thing to remember. Vancomycin, obviously it's right in the name, is not effective in treating VRE because it's vancomycin-resistant enterococcus. So definitely pay attention to that. That's definitely an important thing there. But those are kind of the main bugs or organisms that we've got good coverage from a gram-positive perspective with vancomycin. Some of your gram-negatives, Pseudomonas, the Enterobacteriaceae family, so, E. coli, Serratia, all those things. This medication is not going to have that efficacy to cover that. So gram-negatives are generally a no-go with vancomycin. All right, let's get into kinetics and some of the clinical concerns or implications here. So absorption, IV for systemic infections. Super, super important to remember that. We cannot give oral for systemic infections. The only thing oral is used for is C. diff. Definitely have seen that show up on exams for sure. Distribution, probably the important thing to note here is it does have limited CSF penetration. The exception potentially would be if patients have meningitis and they have inflamed meninges. We may get better penetration there, and it may be effective in that setting. Metabolically, nothing to worry about as far as the breakdown of the drug too much there. That is because it is primarily eliminated through the kidney. So 75% approximately excreted unchanged in the urine. Half-life, so as you can imagine, that's dependent upon renal function, right? So the better the renal function, the quicker the half-life or the shorter the half-life is going to be. The worse the renal function, the longer that half-life. And so classic example, normal renal function, neighborhood of 4 to 6 hours for that half-life. End-stage renal disease, so this is where the kidney is functioning the poorest, if you will. That's up to 7 to 8 days is that half-life for that medication. So important thing, obviously, to monitor that renal function. All right, so clinically, what are we thinking about? So if patients have renal instability, right, that could cause a bunch of fluctuations in concentrations, okay? And keep in mind, vancomycin also can contribute to nephrotoxicity as well. Keep in mind, we're looking for other drugs that are nephrotoxic. So, maybe you've got a patient on cyclosporin, for example, for, transplant or immunosuppression purposes. Maybe you've got a patient, taking NSAIDs, diuretics, those type of medications. These can all have kind of a cumulative effect and worsen renal function. In acute illness, we can also kind of have, altered clearance, altering function of the kidney as well there. Pay attention to, fluid shifts in special populations, obesity, elderly. That may kind of alter that volume of distribution as well as clearance. And then indication and disease severity. We may kind of alter the Cmax as well as the AUC. Consider loading dose for rapid therapeutic exposure. So in patients where we want to get that concentration up quickly, we want to treat that infection acutely. Usually that's in a severe type of infection where patients are not stable and, that infection could potentially be lethal. We're probably going to want to do a loading dose and get those concentrations up quickly. So dosing strategies, let's shift into that. So some considerations. So indication and severity. Okay, what are we trying to treat? How severe is the infection? That's going to be a determining factor in how aggressively, or one of the determining factors in how aggressively we dose the medication. Renal function, are they on dialysis, for example? Do they have great renal function? That may affect dosing and dosing frequency. Weight, special populations, I alluded to that kind of previously. Prior vancomycin exposure, do we have, a history of them being on vancomycin? What worked well for them previously? Are we dealing with the same clinical conditions that we were previously? So looking back in that patient history can be helpful there as well. Concomitant nephrotoxins, may want to be a little bit more cautious if a patient is taking meds that already can cause damage to the kidney. All right, so loading dose can vary a little bit depending upon what we're trying to do, the severity of the infection, obviously. Oftentimes, we'll look for a loading dose of 25 to 30 milligrams per kilograms IV, usually using actual body weight. Round to the nearest 250 milligrams is typically what's done in practice. Maximum, anywhere from 2 to 3 grams in a specific dose. May be institution dependent upon where you're working at and those type of things. Consider loading dose when rapid exposure is needed. I already alluded to that. So sepsis, that's a great example of a very severe infection, life-threatening infection. Endocarditis, another great example there. Hospital-acquired pneumonia. These are all pretty serious and severe infections that may necessitate the use of that loading dose, getting those concentrations higher more quickly. Now, for maintenance dosing, you may also hear it called, intermittent infusion. Usually for dosing, we're looking in the neighborhood of 15 to 20 milligrams per kilogram. Round to the nearest 250, again, similar to, that loading dose. Typical interval for most patients with normal renal function. Remember that half-life was, in the neighborhood of 4 to 6 hours. Typical interval, we're doing 2 or 3 times a day dosing, so every 8, every 12 hours in that neighborhood. Again, that's assuming normal renal function. Now, if a patient has poor renal function, we may extend out that interval a little bit there. So, for example, patient, creatinine clearance of 20 to 50, we may do once daily dosing. If they've got creatinine clearance less than 20, for example, their kidney function's pretty poor, we may consider every other day dosing, okay? So, pay attention to that. Renal function, super, super important to monitor. May cause you to have to adjust the dosing strategy. All right, so we've got therapeutic drug monitoring strategies. There's 2 of them. Historically, we've used trough-based monitoring. However, AUC-based monitoring is typically going to be preferred now. Important to always reassess the need for vancomycin, so check those cultures. Susceptibility, is MRSA confirmed? And can we de-escalate and, maybe go to an oral antibiotic if this patient is, moving on, discharging from the hospital, whatever the case may be. When therapeutic drug monitoring is especially important. So these are situations where we really want to pay attention to those drug levels and monitoring them. So if you've got patient on longer-term therapy, we're going to monitor that more closely. It's probably considered in the neighborhood of 3 to 5 days or longer. Obesity, BMI greater than 30, that can cause some variation in, the concentrations and AUC monitoring. Unstable or changing renal function, again, worsening renal function, those concentrations are going to go up. Improving renal function, your kidney's working better, you're probably getting rid of the drug more quickly. So again, that can cause some variability. Changes in condition, are they worsening? Are their organs shutting down? Those type of things. Critically ill, that can alter some of the concentrations, and we may check drug levels, check AUC monitoring a little bit more closely in that type of situation. Concomitant nephrotoxins can adjust our desire to check the monitoring of the medication, and then, of course, if patients are on dialysis as well. All right, so let's talk a little bit more specifics about AUC-based monitoring. So AUC stands for area under the curve. Multiple society guidelines such as IDSA, ASHP do recommend AUC monitoring for serious MRSA infections, including bacteremia, pneumonia, endocarditis, osteomyelitis. Okay, the target AUC typically is going to be in the range of 400 to 600. Nephrotoxicity risk increases when we get above 700. So again, the higher that AUC goes, the more likely we're run into toxicity. The lower it goes, if we're not hitting our target A1C or we're too low, obviously we're potentially not adequately treating that infection. Assume MIC, so that this minimum inhibitory concentration of 1 milligram per liter. MIC variability does kind of limit the accuracy and the precision. So this is associated with improved outcomes, so monitoring the AUC in complicated MRSA skin and soft tissue infections. Calculated, so AUC is calculated using validated calculators. Depending upon the method for calculation, it may require peak and trough at steady state, so that there can be some variation there. I'm not going to go into a ton of detail on the specific calculators, but just biggest thing I would say, AUC monitoring is typically going to be preferred. Now, there are situations where AUC monitoring may have some limitations, and we may want to try to avoid AUC monitoring, or it may not be as beneficial, and that's changing renal function and patients with severe renal impairment, so dialysis or kidney replacement therapy. And then maybe more non-severe infections, AUC monitoring may not be as valuable. So again, the society-based guidelines really focus on those serious type infections, and AUC monitoring being preferred. There are a couple of methods for calculation for AUC, trapezoidal method. So these are what's called log linear equations used to calculate true peak and trough based upon measured peak and trough levels. The downside to this is steady state must be achieved. So that's a challenge there. Bayesian method calculation may be based on a single level, including pre-steady state. This is adaptive to maybe some of the physiological changes. Downside, software for kind of this calculation and doing this tends to be expensive, so that can be a downside, maybe limited at some institutions that you're working at. Can work with a single level, but better results with peak and trough measurements. So, ideally to measure an A1C, if you could continuously monitor drug levels, that's going to obviously give you, the best result in monitoring patients. Now, that's not practical, at least at this point in the healthcare world. That's not practical to do that, continuously and that sort of thing. So, we have to kind of work with what we've got and where we're at. All right, trough-based monitoring I'll touch on briefly here. So this is used when AUC, area under the curve monitoring, is not feasible. CNS infections, meningitis, there's no convincing data to validate AUC monitoring for MSSA, so methicillin-sensitive Staph aureus, streptococcus, or enterococcus. Unstable renal functions, maybe another one where we're going to maybe get trough-based monitoring as well, or that's maybe more helpful, where the AUC isn't maybe as consistent. Target troughs, typically we use actual body weight, round to the nearest 250 milligrams. With those target troughs, 10 to 15 milligram per liter. That's generally more for non-severe infections, 15 to 20 for severe infections. Troughs greater than, upper teens to 20 and above, that's going to increase that risk for nephrotoxicity, with, kind of 20 kind of being the classic cutoff for those toxicity concerns going up with this medication. Draw the trough typically 30 to 60 minutes before the fourth dose. Earlier, if you have an obese patient, every 24-hour dosing, or unstable renal function. So these are situations where we're going to draw those trough levels and monitor that a little bit more closely. Peaks in trough-based monitoring are not recommended. Linear pharmacokinetics, stable renal function, double the dose. You should get double the level in theory, right? As long as that renal function is stable there. Again, half the dose, you get half the level. Okay, so usually that's pretty straightforward, but obviously in real life and in practice, this certainly can vary. Adjusting after trough levels. So if trough levels excessively low or high, so greater than 0.5, or excuse me, less than 0.5 or greater than 1.5 times the target, we'll probably just change the interval there. If that trough level is slightly low or high, and we're within the 0.5 to 1.5 times the trough level target, we are going to typically adjust the dose. So, those are kind of the two general scenarios that I wanted to lay out. Dose changes, again, with stable renal function, we should get a proportional effect on those trough levels. Interval changes, we're going to get a non-proportional effect. So those interval changes are, we go from 8-hour dosing to 12-hour dosing, or 12-hour dosing to 24-hour dosing. Okay, so worsening renal function or drug accumulation, that's a situation where we may look at those interval changes and pay a little bit closer attention to those drug levels. Lab monitoring, monitoring Vanco levels. Obviously, that's what I'm talking about with trough levels. Also looking at AUC. Serum creatinine at least once weekly if the patient's on stable maintenance dosing. Obviously going to be doing it more frequently in patients where we're concerned about changes from a physiological standpoint, from a condition standpoint. If that renal function is changing, getting worse, getting better, we're going to monitor that kidney function more closely. Okay. If patients are at increased risk for nephrotoxicity, if they're on other meds, new meds started that are nephrotoxic, we're going to monitor obviously a little bit more closely in those situations. Fluid status, if that's changed, if patients dehydrated, obviously that could increase the risk for renal impairment. We're going to monitor again more closely in that situation. Again, critically ill, obese, dialysis or kidney replacement therapy. Those are all situations where you're much more likely to monitor those labs a little bit more closely. After any dose or interval adjustment, we're going to recheck level before the fourth dose if renal function is stable. That's typically what's done. Again, monitor urine output. That can be beneficial as an additional marker of how well that kidney is functioning in seriously ill patients. All right, toxicity, touch on this briefly. So vancomycin infusion reaction, aka vancomycin histamine release syndrome, and also historically known as red man syndrome. This is typically due to the medication being infused too quickly. Talk a little bit about that management on the next slide. We also can have a DRESS reaction. Remember, that's drug reaction and eosinophilia. Drug reaction with eosinophilia and systemic symptoms. Vancomycin is actually one of the most commonly used agents that this is associated with. This can be severe and life-threatening. So pay attention to that for sure with vancomycin. Thrombocytopenia, neutropenia, ototoxicity, dose-dependent nephrotoxicity are all potential very serious or significant complications from vancomycin. And obviously, a lot of those can be risk can be increased when we're using concomitant meds that can also cause those effects. Other things to think about, I think it goes without saying, pretty much any antibiotic you use can cause some, stomach upset, nausea, those type of things. Also can alter potassium levels a little bit as well. Typically, with renal function, we're getting a BMP. So, vancomycin dropping potassium levels, usually we're going to pick up on that pretty quick and obviously be able to replace potassium as needed. All right, vancomycin infusion reaction. I bring this up because it's frequently tested on. Management, reduce the rate of infusion for mild reactions. So I think that's pretty self-explanatory, pretty straightforward. So again, if patients are just mildly complaining of a little bit of flushing, hemodynamically, blood pressure, everything's stable. Like otherwise, they just maybe a little flushed in the face or something. That's be considered a mild reaction. So In that situation, we're typically just going to reduce the rate of infusion, usually by approximately half. Other things we can do. We can treat with diphenhydramine and famotidine for moderate to severe interactions. We may need to interrupt the infusion and stop it and make sure that we alleviate those symptoms. Consider fluid replacement for hypotension. So if patient's blood pressure drop, we may look at doing some fluid there. If a reaction is known from a previous experience with vancomycin, we may do pretreatment with diphenhydramine and famotidine as well. Note if there are signs of anaphylaxis, hives, difficulty breathing, we should treat that accordingly with a medication like epinephrine in our anaphylaxis treatment. So I think that's an important thing to pay attention to there as well. Any type of respiratory distress that appears to be anaphylactic in nature, we definitely have to take that very, very seriously. That wraps up the podcast for today. Thank you so much for listening. This lecture, again, is part of a 30-plus hour review course on Naplex and BCPS. You can find that at meded101.com/store. In addition, if you found this podcast helpful, do me a huge favor, leave a rating or review on iTunes or wherever you're listening. I greatly appreciate that. And of course, subscribe at reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. If you got any comments, suggestions, feel free to reach out to me, mededucation101@gmail.com. Take care. I hope you have a great rest of your day.